Hello, so my name is Milka Kerubo, Bwana, popularly known as Dr. Kerubo. I just want to make this video to give my experience as an intern, to make us understand what it is like to be an intern in Kenya. I know most people don't understand what internship is and its role in the making of a doctor. So I'll just give my experience. And just to start it off, I'll just give an explanation of what internship is. So in medical school, some universities do it for 5 years, some for 6 years. But during this time of study, you are expected to be going to hospital, sometimes daily, and getting familiarized with the hospital environment, with procedures and how management of the patient is concerned, and decision-making processes. So by the time you're finishing and graduating, the assumption is that you should be able to manage patients. But now, because patient care is a whole risky procedure or entrustment, then there's this time that you have to work under supervision. So internship is actually the first year of work, but you work under supervision. And you're given a license to do that. And then once you finish, it's like a preliminary license. Once you finish that working under supervision, then you're licensed to now work without supervision. So in Kenya, by the time I did my internship, which was in 2018, we had 4 co-rotations, and the whole process takes a whole year, which is around 52 weeks. So the assumption is that in these 4 areas, you'll do 13 weeks in each of the areas, which are namely pediatrics, obstetrics and gynecology, internal medicine, and surgery. So there are some other minor areas of interest, like public health. We have areas like psychiatry, which are incorporated in these main areas. So like public health will be incorporated in pediatrics, psychiatry will be part of internal medicine. So it all depended on the center you're in. But how the structure worked is that you find that there's a medical officer intern. We usually have clinical officers. Clinical officers usually do clinical medicine, which is something like a diploma of medicine and surgery, but it's a way in which they have to go through all the study that we do, just that they don't do it as deep as medicine and surgery is done. And there's some procedures that they cannot handle, but at least they are able to see most of the patients that we see and make decisions. Because of our overstretched healthcare in Kenya, then it's a way of at least making it possible for those patients who cannot access a medical officer to still get the help that they need. So clinical officers also go for internship for 1 year, and medical officer goes for internship for 1 year. But now for the study period, clinical officers have a shorter study period than medical officers. So what happens during internship is that it's a time that you have now to practice what you've been learning in medical school in a real patient setup, but under someone who is now qualified to oversee your actions. So I started my internship. I did my internship in a rural area. I can say it's rural because it's not one of the hospitals that were found in the major cities, or it was a level 5 hospital. So the only disadvantage of doing internship in such a hospital is that we didn't have students pursuing masters in our internship center. So it means that the only persons who were under study were the medical officer interns and maybe the clinical officer interns. So the only disadvantage with that is that if you find yourself in a hospital where you have master's students already specializing in different areas, then you're likely to get more exposure to knowledge and experience, and of course they'll help you out in many ways. Ideally, if you're working in a center without master students, then it means that you are the only person who is learning, or maybe the superior most, because the clinical officer interns will be under you. So it's more of practicing what you know and what you can read from books, because most of the qualified personnel are not very available for consultations. So it has to be you finding out from friends from other centers or from the books, because that was our main reference material. So I feel it could have been easier if we had like those master students, because then we could build our knowledge towards those specialty areas. So I started by my pediatric rotation, which was supposed to take 13 weeks. And how was my typical day? First day in the ward was on a Monday. I just got in, and mostly our major ward rounds were done on Tuesdays and on Thursdays. So on Monday when I got to the ward, it was my first day. I just got introduced and we started the ward round. So the ward rounds were being handled by clinical officer interns, because there was some time when there was a gap. So there's a time they didn't have medical officer interns. So the clinical officer interns took over, and they were actually handling those patients and presenting them during ward rounds. So they did the presentations. The ward I was in used to have between 30 and 50 patients, although sometimes they could come down to 20 patients. But the newborn unit also used to have between 20 and 50 babies. So in a typical day, you could see between 40 and 100 patients, depending on how busy the ward was. And just going through that ward round on that first day, and that was meant to be enough to make me ready to do the presentations during the next day major ward round. So I had to just finish, come familiarize with the patients, and the next day I was the one presenting. So it was a day that I was initiated into internship, because that time you're presenting patients, you're supposed to actually give a detailed information about this patient. So you say, this is this and this patient, this is their age, they're male or female, and this is what they came with, their complaints, and how long they've been, and what you found out in your investigations, the decision you made about the diagnosis, and what was your plan of management. And so far, how far have you gone in that plan of management? And are there any challenges you're having? What's the improvement that you've noticed? And what you plan to do in future. So this day I came, and sometimes you're presenting and you're asked a question that you were supposed to do maybe something to this patient, and it's not been done. So you say, it wasn't me. And the consultant could actually tell you that that's not allowed. You can't say it wasn't you. You are the one who has this patient, and you have to do everything. So that's how I came to understand that actually internship is all about taking patients' problems and making them your own, and ensuring that you don't shift blames at any one point. So our major role was actually to crack patients. Ideally, once a patient was admitted, they were supposed to be seen within 30 minutes. So once the nurse has updated in their cardex, which is where they usually record everything that happens to the patient. So if they record that the patient has come to the ward at, let's say, 6, then it means by 6:30 there should be an update that the medical officer intern has reviewed the patient, and this is what they have decided. So most of the time when the consultant could come, that is our supervisor, he could just come straight and start reading the cardex. He's not even interested in what you've written in the file. So it's from that cardex that they could be able to tell if you actually responded in a timely manner, whether you saw the patient at the right time, and whether you sorted them out. And reviewing a patient actually meant a lot. It wasn't just seeing them, but you had to take a full detailed history of this patient. If you have an investigation that you needed to do, then you had to do them at that point. And any decision about management had to be made at that point. And unlike most of the hospitals, I think as we didn't have the luxury of having phlebotomists, so as a medical officer intern, if you make a decision to get a blood test done, then it was your role again to take that blood and take it to the lab. So you had to get the blood from the patient. If you wanted any imaging done, sometimes you could find nurses could take the patient to the imaging department, but sometimes they couldn't. And if you come and maybe you're reviewing the patient and the results are not ready, of course you'll be inconvenienced. So there are times that you just decide to do the taking of the patient to the imaging department on your own. There are times that maybe you requested for some medications to be given and the patient does not have a cannula, so you have to fix that cannula and make sure that it's running. So those are the things that you had to do. So it's mostly involved making sure that the patient is fully settled. And sometimes when you take samples to the lab, there could be cases where samples could be misplaced. Sometimes they could overstay and not be viable for testing. And so what used to happen is sometimes you had to go wait for the results or keep checking so that the sample you took can be prioritized, because sometimes there are so many samples that came from different wards, from the outpatient department, from other hospitals, from outside. So you'll find that whoever is in the lab is actually overwhelmed by the samples and they could choose to do the most urgent. So unless you went and made your sample and request look urgent, then you could end up having to go back to the child and getting a new sample from the child, which was a bit hectic. For those who know, actually getting samples from the babies is not that easy. It's very hard. So with time we learned to master some techniques like broken needle technique, which has really, really, really worked for me. Even now, I still use it. And there are things that once you get them right, they give you an easier life or an easier stay. So that's what we used to do. And part of our labor also involves fixing cannulas. And babies, for some reason, they just keep removing. Sometimes they are misplaced. Sometimes those cannulas start leaking and you have to come and refix them. So it was quite a task, especially if you get a plump baby with no visible veins, then you had to really spend time with this baby. So with time we had to perfect the art of actually doing that, but that was the role of also a medical officer intern. Another role that we had was of fixing nasogastric tubes, that is feeding tubes for newborn unit babies, because then it was expected that every feeding time, as a medical officer intern, you had to be around, make sure that all feeding tubes are working for the babies who need nasogastric feeding, and if they're out of place, then you had to refix them so that when the mothers are coming to feed them, then they could find an easy way of feeding those babies. So that's what we had to do. Every medication time, sometimes they could schedule the treatment times. So they could give medicines at around 3 a.m., 6 a.m., 9 a.m., at 12, and then maybe at 4 and 6. So those times they're giving medicines. As a medical officer intern, you had to be around, because how it used to happen sometimes, if the nurses are going around to give medications and they find that the cannula is blocked, for example, or it's leaking, they couldn't even inform you. So they could just indicate on their cardex that they did not give the medications because the cannula is blocked, or because the cannula is leaking, or because the baby doesn't have a cannula. Sometimes the babies remove the cannulas, or by accident the cannulas get that's just removed. So they couldn't even like call you. They could just indicate it. And then on the treatment sheet, so they just write NL, that's for no line. So when you're doing your ward rounds, the role of the consultant will just be to take that treatment sheet and look at it. And if they find a gap where there are times when the baby did not receive medicines, then it could be a problem on you as an intern. So you had to like pass by every treatment time to know how the treatment went. How are the cannula? Is there any that is not working? And if it's not working, then you are the one to fix it. So this actually made it be like you have to be on duty every time. There is no resting. And there are times that we could even like you stay in the hospital and just go to your house to change. I remember there's a time I stayed for like 3 days without eating. It was a time that we were overwhelmed. You know, there are those seasons that are very cold and babies are sickly. So I had a very full ward with very many emergencies. And for some reason, I just kept thinking that I would finish all the work and go eat. And I remember sometimes I could go to the house and bathe, and then just when I want to take a nap and you're called for an emergency and you come, and even sometimes you're leaving to go get something, grab some food to eat, and someone just comes and they're pleading with you and tell you, there's this very critical baby, kindly just come. And when you go see this baby, you get another baby and another baby and another baby, and the day is over. And because I was in a rural area, if you leave the hospital at around 8 p.m., there are no shops that were open at that time. And I hadn't really had a plan of how to get myself stocked up with food. So I used to buy food to eat. So there are times I could go hungry because I left the hospital very late. So for these 3 days, it happened that every time I was ready to go eat, something came up. And by the time I was remembering and trying to recall when last I ate, it was actually 3 days gone by. I hadn't put anything in my mouth. So sometimes it can get that busy, but that was during my pediatrics. I remember there's a time I got sick, and that time I had malaria and started on medications, and I had informed my second on call, we call them. That's someone who is a medical officer but qualified. So that is there someone who you are working under. So I informed her that I'm very sick, and they just told me, just make sure the ward is settled before you go, then I can cover you for the night. So the good me had to like fix every line, make sure everything is okay, every baby is restful, and there's nothing pending, no review to be done. And I called the doctor at around 11 p.m. and told them that I'm now done and kindly just hold for me now. I can go and rest. And mind you, by 4 a.m., I was already called by this doctor. And they said the night is over. Now you can take over your shift. So I had to wake up, and there was already a baby who was admitted that needed to be seen. So I had to go and see. And that was the longest I slept for those 3 months. I slept for 4 hours. Before then, I used to sleep like 30 minutes, 1 hour, and you called. And because of this time that you have to see the baby within 30 minutes, even if it's a stable baby, you cannot rest. You had to go and see this baby. So it's a time I can say that was good because it taught me discipline, but it was quite intensive. It was quite intensive. There's a time that I can remember I went to see a baby who was admitted in shock because of diarrhea and had been resuscitated. But when they came to the ward, somehow their cannula got some leakage and fluid was seeping into the tissues. So the hand was swollen. So by the time I came to see this baby, the baby was already back to shock and unconscious, and the hand was swollen, the fluid was not going. So I had to go fix the cannula again. And being a resource poor setup, we actually didn't even have proper lighting. So we had to shift the baby to the emergency room and do the cannulation. And by the time we were giving fluids and everything, I think it was just too late because the mother had not realized the deterioration in the level of consciousness of the baby. So by the time I came to see this baby, they were already very, like, way beyond we could help. So by the time we were getting a cannula and fixing fluids, it didn't even take long. I think within a span of 5 minutes, the baby had already collapsed. So what happened is we lost this baby, and the parents blamed it on me because for them they thought the baby was okay, and according to the mom, it's me who came and told her that the baby is not okay. So when I told the mom that the baby is not okay, she didn't take it lightly. She said, this doctor came and told me the baby is not okay, and shortly after my baby died. So she blamed me because everyone else had told her that the baby is okay, and now I'm coming in to tell her that the baby is not okay. So she said I sacrificed her baby because That's the only way she could understand it. Now, they wanted to beat me because they think the relatives had come and she had called everyone and she told them there's this doctor who just sacrificed my baby and I was to be beaten. So one of the clinicians who was there, he had a commotion and he called me and he told me, just find a way of getting out of that place, because I think he had worked there for some time, so he knew that things can get out of hand. And I pretended to have received an emergency call. I went to the newborn unit and stayed there. So they didn't see where I went. So they didn't follow me, luckily. And I stayed there up to around midnight. When the situation had come, then they had gone away. Then I was escorted by the security to my house. So from there, I actually used to live in fear because I didn't know if any of the relatives who had a problem could actually decide to wait for me and harm me on my way to hospital. But those are some of the things that happen in hospital. Sometimes patients don't understand that the person they think actually harmed them is the person who was meant to help them or who intended to help them. But because they couldn't understand the situation of the child and they never had that time to listen or wait to be explained to what happened, then they had their own preconceived notions and beliefs. And that's how they ended up thinking that I'd sacrificed their baby. But that was a situation that I may not forget, because it's a time I could have been beaten badly or maybe injured, but somehow I got saved from that situation. So that was my pediatrics. When I was around the 10th week finishing, the doctors in my area went on strike. So I was remaining with around 3 weeks. And for like 1 week and a half, I was trying to settle the babies who were still admitted and finding them referrals. Because you see, you have to call every hospital and know if they can accommodate the children and how many they can. Imagine having 80 children to refer. So in one day, you could find like referral places for 7, and then you have to wake up again the next day and start making calls to other hospitals to try and find secure spaces for these babies. So it took me around 1 week and a half to finally settle all of them. And because I was a medical intern, not registered, so I didn't belong to any trade union, or I didn't have a right to go on strike. So that is how comes I found myself in that situation. But when the strike was finally over, after waiting for like a whole month, when I came back to clear, I was told by my supervisor that that 1 month, 1 week and a half that I had worked was unsupervised. So it couldn't be counted. So that was the most painful thing that happened, because I expected that I remained with 3 weeks, and for 1 week and a half I was still working. So I should have remained with 1.5 weeks, but I ended up doing all the 3 weeks because the 1.5 weeks was not supervised. So I had to like redo the 3 weeks. But that's how the medical profession is. If someone decides that they have not supervised you, there's nothing you can do. You just have to do whatever they require you to do so that you can be cleared from that. So when I moved to my next rotation, which was obstetric and gynecology, pediatrics, I was the only intern in that rotation. So I had to work 24 hours, 7 days a week, no weekend, no holiday. I never went home, yet my home was like 1 hour drive from that place. And I never had like that good rest. When I got into obstetrics and gynecology, we were 2 interns. So we divided shifts, and how we used to do it is we used to do alternate nights. So if one person did one night, the other person did the next night. And during the day, on weekdays, we had to be on duty, the 2 of us. And the requirement was that the evening ward round, because we used to do a ward round in the morning and in the evening. Morning at around 8 a.m. Evening, we used to start the ward round at around 6 p.m. And the ward round could go up to 8 because we used to have very many patients. So if we start a ward round at around 8 a.m., maybe it will go into 11 a.m. And then when we start a ward round at around 6 p.m., we could finish at around 8 p.m. So if you were doing day shift and going to rest for that night, it meant that you leave the hospital at 8 p.m. But if by the end of the ward round there are like operations to be done or procedures, then you had to help the person who is remaining for the night. Because in most cases, by the time we're finishing the ward round, there are already many referrals on their way coming, because patients used to be referred to our facility from those hospitals that didn't operate at night, didn't have operational theaters at night. So you could find that there are like 3 to 4 referrals, sometimes 7 referrals coming, and you already have like 3 mothers lined up for cesarean section. So what could happen is that the person going to sleep will need then to help this person remaining to work to settle the ward. So they'll help maybe in doing 1 or 2 surgeries before leaving. So in most times you could find that the time you leave the hospital was at around 9 p.m. And when you go to sleep, then you had to be back to the hospital by 7 the next day. Because if the ward round was to start at 8, then you had to do what we call a pre-round. So at around 7, you had to like get your things ready, get all the files ready, identify the mothers who are due for review and check them, so that by the time you're doing the ward round, you're presenting the current situation of the patients. So if you went home at 9 and came back at 7 in the morning, then that left you with around 10 hours of resting. So it meant that out of the 48 hours of a 2-day shift, you had 38 hours of working and 10 hours of resting. And that's how the cycle used to be. And every weekend, we used to do alternate weekends, because at least on weekend days, we didn't have to be there, both of us. So we used to do one weekend, one person covers fully, like day and night, and the other person rests completely. And then the next weekend, this person who was resting the previous weekend could come in, and the other person could like rest. So that's typically how our rotations were. But it was more of getting used to the whole routine. Sometimes we could get very tired, but the good thing is that most of the time, if the body needed to act, then you got some energy. That's adrenaline just came. So there are times that you find there's an emergency and you're very sleepy, but for some reason the sleep just goes away and you have to spring to action. And there is a time that we didn't have a Doppler, so we used to use a fetoscope to listen to the fetal heartbeat. And there are times you could actually be there counting the fetal heart rate and you doze off. But the good thing is you used to do a ward round in a team, and the team understood that you're tired. So they just helped us go through it. But it's a time that we had to have to do it, because that was the requirement. You couldn't delegate the work to anyone. You had to see every patient. You had to review every patient, and you had to do all the procedures, and you had to still respond to emergencies. So if you go to theater and you have a procedure, you have to have it in mind that you have to go back to the ward and check the patients once they are due for review. So that was essentially obstetric, and it was quite interesting, because by the time I came to internship, I had already done my first 2 CSS, so it wasn't very hard, cesarean sections. So day 1 was just introduction, getting to know where things are in the theater. And once I just observed my first surgery, the second surgery I assisted, the third surgery I was already doing it. And within the first week, second week, we were already doing the previous scars. And I know most people used to fear mothers who have previous scars. But from my experience, because I used to do like 5 surgeries during the day, 7 surgeries at night. So in a 24-hour shift, mostly you do between 10 and 12 surgeries. And I could say that it's never predictable. When you're going to theater, you just go with an open mind. Because sometimes you could go with a mother who is the first time to go to theater, and you find that it's a complicated surgery. They can have bleeding that is not stopping. And sometimes you could go with a mother who has had 3 previous surgeries, and you have a very smooth surgery with very nice outcome, So sometimes you can't really predict what you're going to find in theater. So you just have to be prepared for anything. And the best you can do to yourself is to get as much exposure as you can, because then the chances that you'll get something that you've never encountered in the past are very low. So that gives you a lot of confidence, and it makes you actually make some good decisions when you encounter these challenges when you're going into theater. Now, when I finished my obstetrics and gynecology, just before I talk about that, I think my worst experience in obstetrics and gynecology was a loss of a patient. So sometimes you could find these patients who have gone through many surgeries and they are trying to get pregnant. Some of them want to get a certain gender. Some of them want to get a baby because maybe they have not succeeded. There are cases you could find a mother has gone through surgery for like 3 times and still has no living child. So there are times you could do a 3rd, 4th, 5th cesarean section and the mother has no child. So if you lose such a mother, like a case that happened, we lost a mother who was doing their 5th surgery, and somehow we couldn't stop the bleeding and we managed, but during recovery and post theater, they just went into active postpartum hemorrhage, and we lost that mother. And it was painful because this mother actually died trying to bring forth life. So that taught me that anytime you have a chance to give someone that outcome of a child, a healthy child and a healthy mother, they just do it, because you don't know how much this person has tried or how much they value that. So every chance lost may be another risk of this person trying to actually get another baby. And that's how our African mothers look at it, or maybe society pushes them to look at life and childbirth. So that made me to actually value and try as much as possible to end up with a good outcome for both the mother and the baby. Now, when I went to my next rotation, which was internal medicine, I think it wasn't as bad. Internal medicine was less of practical work and more of theory work. So apart from just getting samples and doing some few procedures here and there, it was more of just making decisions for patients. And once patients come in critical conditions, within a very short time, they stabilize. Once they stabilize, then you just write the plan of care, get whatever samples you need to get, check them, and just relax and wait for them to be ready. So I think apart from the fact that you still have to stick around and make sure that everything is put, because by the time the doctor is coming for the ward round, you had to have all your things ready. So there's nothing like I took the samples to the lab and they're yet to come back. You're the one to go and get the results. So sometimes we could just go and sit in the lab and wait for the results. Sometimes you could have to call the relatives if they have to pay for some tests outside the hospital and talk to them and wait until they come so that you can make sure you give them the samples to take. So it was more of you just sticking around the hospital, but not really getting tired doing anything, not like obstetrics and gynecology. But what I came to realize with internal medicine, the main challenge was actually finances, because some patients could not actually afford. They couldn't afford some of the things that were required. Some tests were needed to be done outside the hospital and they could not afford. Some of them needed to buy, like the patients who were for dialysis because of kidney injury, and they couldn't afford a dialysis catheter. So there are cases where we lost the patient because they couldn't afford that. So that was the most painful thing about internal medicine. It was good, but there are cases where you were not able to help the patient because they needed to get help elsewhere. And if they did not then manage to do it or afford, then you couldn't help but then to just watch the patient deteriorate. So that was the painful part about it. I remember there's a case where we had to stay without having a CT scan for the patient until we decided now to just take them to theater, because they were having this abdominal pain that was not resolving and they couldn't afford a CT scan. So we had to go to theater and found that it was a thrombosed vein with the gangrenous intestines. So those are the things that happen in internal medicine, that it is investigations that will help you know the next step of management. So if a patient cannot afford the investigations, then some of the times we could just go for ward rounds, and you find that maybe you indicated that a patient needs a certain investigation. The next day they have not done. So again, your plan remains the same to do that investigation. The third day again, you go for ward rounds. They have not done the investigation. So still the plan remains to do that investigation. I think I found that very, very boring and wasn't very good. I didn't try like that part. So I feel medicine can be more interesting when things are moving. Like just make a decision, decide what you want to do it. That's what I liked about obstetrics. But in internal medicine, it has to be with the cooperation of the patient, or if then you're in a facility that can do all those things, then I'm sure you can really enjoy. And one thing I came to also understand about internal medicine is that diseases are really, really linked. So you can't really just look at a patient and look at them from one end. So there are times that you could request for investigations and they came out inconclusive or normal. And for some patients, that didn't just settle well with them. They used to feel like you wasted their money because maybe you made them pay a lot of money to do a test to rule out a disease you thought about. But from their angle, they can't see that. For them, they think you just wanted to use their money to do those tests and the disease is not there. So they don't look at it from the point of, at least now we are sure it's not this. To them, it's like this is now money gone to waste. And I think that was the challenging part about internal medicine. More on such, it was a good rotation. Then I went to surgery. Surgery was my most enjoyable also because we had a program of surgeons who used to do masters. They do masters and study and work. So there are times we could wake up in the morning, just go for their classes, attend their sessions where they do discussions. And after those discussions, then we could go for ward rounds and do the ward rounds with them. And after that, then go for theater procedures. So it felt really nice having those master's students because they were like holding your hand and teaching them you. So you have to make decisions, yes. But if you needed to consult, then they were there to consult. It was difficult to consult the medical officers who were there qualified because some of them were not very friendly. I remember one time I needed some consultation, so I called one of the medical officers and they told me I should read my books because I have books and I should read books. So it was difficult because, by the time you're calling someone, you probably have read and you've not reached a conclusion. So you need them to actually make some decisions. But then they don't want you to call them. So when you call the consultant and the consultant asks you, what did your medical officer tell you? So when you tell them what they told you, then now you've set them for conflict. Now they start the consultant will now want to investigate and find out why the MO was telling you that. And that brought you into now crash with the medical officer. So I didn't like that. Most of the time I used to just do a lot of reading around it. And that's why I found it so easy now to do my surgical rotation because I had my colleagues who were also students and who needed to stick around the hospital as long as I also stick, who have interest in that area of study because they're already studying that in masters. So they could actually feel happy when you consult them because those challenges actually were making them to better their understanding. So they were very eager to help, and I feel that was part of what I really enjoyed in my internship. Having someone who is doing masters in their area of specialty, in an area where they're interested in, and they're happy to be inquired. They're happy to be called in to help. So one thing I came to realize about surgery, it's quite not very intensive like obs-gyn, but it needed a lot of patience because some surgeries took long. We could take 4 hours, 5 hours. Though I had a strong core, but that's an area that can take your time. Like you could do one surgery for very long. And of course, now there are the other challenges of you want to go into theater, but because most surgeries don't come as emergencies, you know, not like obstetrics and gynecology, but in surgery, you could find an anesthetist who is just not willing to let in the patient because they want to buy time for their own reasons. So as a surgeon, you have to sit there and wait. And I think that's where they used to really waste a lot of time. So it wasn't busy, just time wasted intentionally for some reasons, and maybe sometimes the procedures that used to really take long. But it was interesting, and I enjoyed it because I learned a lot from the master students, had a companion in them, and at least I can say that it's an area that was very rewarding. We were many, but we had to like cover the ward, which was very busy also, outpatient department also, which was very busy. The only challenge we had with patients in surgery was that some of the diagnoses in surgery were terminal, especially the cancer diagnosis. So it was painful to just see like patients come and you break those news to them, and they come to understand that this is the condition we're dealing with. And some of them, if they don't take it lightly, then, or if they don't accept the diagnosis and take it positively, then they ended up hating you as a doctor and feeling like you are the one who has also contributed to that diagnosis. I don't know how that used to happen, but I came to understand, even post-internship, there are some things that I've come to understand and accept in life. That diseases come to patients as an interruption of their routine. So in their own, by the time the patients are coming to hospital, most of them are already frustrated. Some of them are sick, they're just feeling bad. But also, given the financial burden that diseases come with, some of them have also those pressing, the pressing issues of finances. And so by the time they're coming to you as a doctor, any human being who is going through a lot in their life, any human being who is going through a frustrating situation, they are likely to just react and hurt the person who is next to them. And here it happens that you as a doctor are the one who is vulnerable to now facing the brunt of it. So you find most of the patients, sometimes they could come and be very hostile to you. Some patients could be very rude. Some patients could choose not to cooperate, not because they have anything against you. Some of them don't even know you, but simply because this disease is coming as an interruption to their normal routine and unplanned event, given the many things that they have to adjust in life. Then they end up now like pouring out their frustrations, and how they act it out depends on how they have taken in the information. So you find some of the patients will act very rude, or they will just be negative, but they have nothing against you as a doctor. So you're not supposed to really take your feelings to work. So one thing I came to realize is that for medicine, you have to have your intention to help the patient as your key guiding principle. So how the patient treats you should not actually change your way of action. So you have to understand what you need to do for the patient and why you need to do it. And because the patient doesn't understand that, then you have to be persistent and patient until this patient reaches a point where they can trust your intentions. So that's one thing I learned about disease. The other thing I came to realize with patients is that they don't understand medicine. They don't read books. Diseases also don't read books. So as a doctor, you have this knowledge you have. But because patients are not in your level of understanding, then they have a right to not agree with you in most of the things you could tell them. So it's not uncommon to find a patient, you tell them what you want to do, and the first reaction is to resist because they don't understand. So it is their right to do that. And as a doctor, then you should go the extra mile to try to lower yourself to their point of understanding. Try to understand their fears and what is making them not do what you're saying or have the concerns they have. Then address those ones. And once you address their concerns and show that you're actually willing to go through the whole process with them and wait for them to make decisions, then it means that they will trust your intentions and they're likely to cooperate. Just that now it needs a lot of persistence, and you never have time to like rewind. You just have to keep moving, because I think that's an area that as a medic you have to understand, that if you get a bad news or a bad outcome, or if a patient is not cooperating, you still have to maintain your cool and be sober and make decisions without being compromised. So it's an art that we learned to practice through that period of internship or even being a student. And another thing that internship helped us is to culture that habit of always putting the patient first. Because I remember all this time we used to sacrifice. Sometimes you've not eaten, you've not slept properly, but because the patient needs your attention, then you have to like be there for them. And that actually helped me, because like I can't sit and relax when I know there's a pending patient waiting and all that. So it's something that you cultivate through time. But internship may be very intensive, but it's what makes you a good or a bad doctor, depending on how you adjust to the situation. There are times you could find supervisors who are very hard on you. Like in my case, there are times I could somehow feel like they were being unfair, because if I was to review a patient at a certain time and I reviewed them late, like by 20 minutes, their consultant who could not take that very lightly. But a colleague does the same thing and they don't like get the same strict approach to the same consultant. But this happens even other areas of life. But how I came to look at it is, in most cases, everyone gets to understand the potential of their student. And if someone realizes that you have potential of becoming a good doctor, then they would rather push you to get into that full potential than to let you just, like there's that temptation of trying to settle for less. But if you have someone who is going to push you to become a very good doctor, then just take it positively and go for it. Because it's through that pressure that you finally come out as a fine doctor, someone who can make decisions very fast and the right decisions. And I believe through my practice, if at all there's anything that I've done good for my patients, it's because of the kind of pressure I went through as a student and as an intern. So I've learned to take pressure positively, because I believe that it may not be necessary, but sometimes it is what will make you go to another extent that you could not go if you didn't have that pressure. So if you have to achieve more than you are achieving at this point, then you need that extra push. It doesn't matter what kind of push you have, but every challenge that is pushing you to do extra work then is actually making you a better person. And you're going to finally achieve what you could not have achieved if things came to you easy. So that's internship. It's just 1 year, but it's the whole of your lifetime. Because when you go through it, you learn so much within a very short time. And by the time you come out now to practice, you find that you're very confident. And if you find yourself in a situation where you have to make a decision, improvise some things, then you find it very easy because you're used to that. That is what you're trained to do. And I think that's what it takes to make a doctor in a third world country. And I'm sure if you were in a first world country, maybe the experience is different. But in a third world country, then you have to go through these challenges, because that's where our patients are, and that's where we have to start from so that we can help those patients.